Hey guys, am I audible, visible? If so, say me a hi and a hello. Hello guys, am I audible, visible? I can't see myself. Just give me a second. Hello everyone, a very warm welcome and a good evening. Can you guys see me? Hear me? Hello both students on YouTube as well as in the app. A very good morning. Hello, thank you Deep Ghosh. So let's start today's. It's a very basic introduction of what we are going to see in pathology and how we are going to overview the entire Nishchay Batch students, right? So welcome everyone. I'm Dr. Ranjith. So every day in the first slide, what we'll be doing is pranam. Hello everyone. So what we'll be doing is I'll tell you exactly what competencies I'm going to cover in that class, right? So here today there are actually 35 different competencies with respect to pathology, and under each competence it'll be like 1.1, 1.2, 1.3, 2.1, 2.2 and 2.3, right? So we'll be covering all the 35 different competencies. Whatever is there in Robbins, we'll go with Robbins. There are few competencies which are not there in Robbins, and that will go here, right? No Kajal, this is just a demo session, so it'll be there on YouTube. Everything else will be there in the app. I have both the screens here. You can comment on both the screens. I'll try to reply most of your queries in either of the screens. Fine. Okay. So this is what we'll be discussing today. Competency 1.1 and competency 1.2, which are very non-specific. Like what's the role of pathologists, the common terms and definitions to be read in pathology, right? That's what we'll be covering. And like this, I said, I'll be also using the same competency, same wordings, what is there in your CBME curriculum. If you want to get the CBME curriculum, you can go to the NMC website and you can download the CBME curriculum easily, right? So we'll go exactly as per the CBME curriculum. We'll not move here or there. Whatever is there in Robbins, we'll go with Robbins. There are few competencies which are not there in Robbins. I'll definitely give you a structured view of everything. Fine. So what I will do in the first half or maybe first 5 minutes here is the overview of what we are going to exactly do in Nishchay and why this Nishchay batch is required for and second prof student, right? So how was your first year? Let's make it more interactive. First year was good, bad or ugly? How was it? I want you guys to comment here. It's fine, whatever it is. Any doubt, if you have, ask us. That is the only role of a live batch. Whatever doubt you have a doubt with spelling of pathology, we'll definitely sort it out. That's the job here of me. So if you have a doubt, please do ask. Ugly, average, mediocre, right? Okay, great. So now the second year is something which is kind of called as in preclinical, right? So we have preclinical, the first year, and we have the paraclinical, and we have the clinical. So this is how your entire MBBS is being moved, right? Hello, PD. Sure, creation, you can do it. Fine. Unpredictable, right? Perfect. Now let's see what to do. So your preclinical subjects are your anatomy, physiology, and your biochemistry, right? That is your kind of a very beginning base. So everyone in future wants to treat someone, diagnose something, and to have, how many of you are fans of House MD, Good Doctor? How many of you want to be like Sean Murphy? Plant a lot, achieve less. Gosh, that will be the lifetime statement of every medico ever. You're told it, some of them has not told it, that's all. Want to be like your good doctor, right? The surgeon, right? Definitely. Or the house MD person. We always aspire to that, right? Perfect. But what happens is the medical series, what we watch and what is there in the reality is a huge gap. That's why we kind of don't fulfill that, right? So now we are in the second year of paraclinical. So you must have read about anatomy. Anatomy is one of my difficult subjects as well. I'll be very open about that. And physiology and your biochemistry, right? We have three subjects here. So if you know normal, we can easily extrapolate abnormality. The best word which I love in medical science is extrapolation. If you have listened to my lectures at least once in a class, I'll tell we can easily extrapolate to your pathology. So once you know pathology, if you have a basic understanding of your physiology, you can go and extrapolate the symptoms, the signs. Okay, it's very simple, right? Let me give a very simple example of how all these are linked. What's the treatment of fever? Very basic treatment. What's the treatment of fever? Ramesh, if you're in the first year, go with the first year batch. That'd be the best thing for you. Anything is okay, Vinayak. Basic treatment of fever is Dolo 650. That every one of us knows, right? That's all. So here, the paracetamol or the Dolo acts via a prostaglandin. It's going to block the prostaglandin. In pathology, we will read that any disease happens, prostaglandins will come into play. So prostaglandin is the one which is going to cause fever. And in pharmacology, that also comes in your second year. You will read that I'll be giving paracetamol, the dosage, the route of administration for a kid, for an adult, for an elderly. And in microbiology, you will read that what is the organism which will cause sore throat. This is just a simple example because all of you must have gotten sore throat, right? Just a throat infection. You will read in microbiology what organism causes it, little bit of toxins and everything Dr. Mamta will take. I'll be telling exactly when the organism comes to my body, what will happen in my tissue level, right? That's a thing, right? Uh, Gamer, the bigger book is always better. So that's why I suggested the bigger book, fine. So once you know about the pathology, the prostaglandins and everything, you go to pharmacology, you know that if I block that, this happens. So this makes your base very, very, very strong. So my question is, do I need to know physio for this? If it's good, it's great. If it's not good, it's fine. So if your first year has not been good, if you think your first year is not good, don't worry about it. Whenever I go with any pathology, I'll start with the normal physiology. Little bit, not much. I'll give you a simple example, right? I'll definitely look at that panda. I'm also not able to see your comments. I'll definitely look into it. Okay. The app will be sorted very soon. Okay. So now let's have a look at it. Like I said, let's find a simple correlation if we are able to extrapolate. Just extrapolate is the word which I love a lot. Okay. I'll ask you a simple question. I want everyone here online, if you are a completed first year, to answer this, right? Everyone knows about a hormone called as estrogen. You must have heard. Definitely. Yes. Definitely. Right. In menstrual cycle, which phase of menstrual cycle there'll be estrogen predominance? Is it proliferative? Is it secretory or menstrual phase? BSS, yes, we'll definitely look into it. As of now, I can't sort it, but I'll definitely look into it. BSS. Proliferative phase, right? That's completely easy. Everyone knows that it's in proliferative phase. Proliferative phase is where I'll have more estrogen level. Am I right in saying when I have an ovulation, the estrogen level kinds of drops and then the progesterone level picks up? Am I right in saying that? Definitely I'm right in saying that, right? Perfect. So now let's assume there is no ovulation happening due to some disorder, because when ovulation does not happen, it's abnormal. That's what pathology is, right? I am not having ovulation. I'm going to call it anovulation, right? Absence of ovulation is anovulation, right? So when I use the term anovulation, ovulation is not happening. So what do you think will happen to estrogen levels? Will it still be elevated or it will come down? Just a simple correlation. Yes, Tanmay, yes, Ananya. Will it? It will still be elevated, right? Perfect. So anovulation is a pathology here. So simple physiology enough for me. I don't want you to have distinctions. If you have attended menstrual cycle, you know that estrogen is responsible for proliferate phase. That is enough for me, right? So if my estrogen levels is elevated, estrogen causes proliferation. When there is more amounts of estrogen, what do you think will happen to endometrium? Will it grow bigger? Will it grow smaller? Grow bigger, grow smaller. It grows obviously bigger, right? This is not rocket science. I don't want you to excel in physiology. I don't want you to be a smart student. I don't want you to be an extremely high IQ person. You can listen to us. You can think, that's more than enough. It'll become bigger. Perfect, right? Great. Stay with me. This is what happens in pathogenesis. Now I'm going to give a term to this. If it's going to become bigger, I'm going to use the term endometrial. Can I call that hyperplasia? Perfect. So this is pathology. I name it endometrial hyperplasia. So because the endometrium became bigger, we will see whether hyperplasia or hypertrophy when we go to the proper lecture. I'm just giving you an example of how we are going to correlate, right? Now I know pathology with this simple physiology. My only question is, if you don't know that estrogen is involved in proliferative phase, it might be difficult for you to extrapolate. But still, I will tell that yes, estrogen is involved in proliferative phase. Let's use that to extrapolate, right? Perfect. Now, like I said, if I know paraclinical, clinical is very, very easy for me. Let's extrapolate. I want you guys to answer. Whoever is online, do answer here. My endometrium has become thicker. Normally thin, it's become thicker. So what do you think will happen to the menstrual bleeding? Will it become more or will it become less? Just a random question. What do you think will happen to menstrual bleeding? More or less? It undoubtedly is going to become more, right? Right? Perfect. Bleeding, what do we call it in general? What do we call bleeding in general? We call it hemorrhage, right? That's a technical term here, right? So here it's a menstrual hemorrhage. So we use the term menorrhagia. That will be the symptom. If I know what's happening in the person's body, I can tell what will be the symptom. Menorrhagia. That's all. Right? So if I know every normal thing, I'm just going to make it slightly abnormal and we are going to make the clinical symptom taken care of. So once you know menorrhagia, when you go to OBG, Dr. Oshika will tell you many causes of menorrhagia. That also you can easily extrapolate if you know this, right? So that is the bridge what second year gives to you. If you know normal, I'll definitely make the level best of my knowledge to make you understand abnormal. If you understand abnormal, definitely the disease is not a problem. You need not memorize. If you are with me, you need not memorize. I cannot memorize, so I'll never tell my students to memorize. Because for a doctor, you need logic and common sense. You don't require much memory. We have chat GPT, right? We have chat GPT. Ananya, I'm a pathologist. I'll take second year. That's one subject which I know better. So I'm just sticking to that, right? First year, we have experts. They'll take care of you. Fine. Okay. So now when we have memory is not an important thing for me at all. To ace, please listen to me. To ace NEET PG, even to be in the top of NEET PG, memory is not important. If you understand the logic behind things, I do need memory to remember estrogen in proliferative phase. These things are required, right? Rest are not required. Ghosh, can you just put it back again? There are too many comments, so I might have missed it. Fine. So we need not require much of memory. We'll just go with simple logic, extrapolate and do wonders. Fine. Okay. Now what I wanted to do for this Nishchay batches, since taking notes has not been the dictum for most of you guys, right? Tell me how many of you really write notes or you just buy the notes and then you mark tick on that. What do you think? How many of you write notes and how many of you buy the notes? Be it in your class, be it in the batches. Generally, there's a kind of movement from the students from writing a notebook towards taking a Xerox or taking something, right? If you write, best. Buying and marking, I'm okay with it, right? Only thing is, when you write something, not just your exam or anything when you write, can I say that if you remember your anatomy, your Broca's area, every area in the brain will be involved for writing? Definitely, right? So for me to, if I'm going to put something in writing, I will eliminate all the unimportant things. I will write only the important things, right? We listen, we remove it, and then we write it. Fine. Okay. So I always would love if you write. That is what I'm an old school person, right? I'm very old. So I always like if you write, right? So I do understand writing completely with the lecture is difficult. That's why this batch I'll be going with workbooks. Workbooks will have a template. So the bigger problem is Robbins is not having a template. Let's create a template for Robbins, right? The entire workbook will have a template. So it will be written definition and the definition will be typed there. So you know, write the definition. Fine, you not write the definition, it will be there because there's nothing for me to teach in a definition. So why should I waste time in writing in a definition, right? So the definition will be there, the headings will be predetermined, and I'll put this workbook on the PW Telegram channel before every class. If you're used to taking soft copy note, use that, or print it out and take it, right? I'll try to put it entire chapter of workbook at the start. My first lecture will be starting by next Monday. I'll try to put by weekend the entire chapter's workbook. So take a printout of that and start writing, because I always feel that the faintest ink is stronger than the strongest memory in the world. So write. Once you write, you will understand. Only then you can write it. When you don't understand, you'll have a doubt, ask us. We are there to clear your doubts. That's all. Any doubts what you have under the earth, please do it. Fine. Fine, Hardik. If you are able to do that, amazing. If you have any doubts, do let me know. Fine. Okay. Now, just two CBME topics here, which is not very hardcore pathology. Let's quietly discuss about them, right? It's about discussion. I'm not going to teach because both these topics are more of discussion than of teaching. Fine. Okay, let's go to it. It's PW Medet. It'll be a Telegram channel. Just go for that. Fine. You search in the Telegram, you will be able to see that. Okay. So what is the role of pathologist in a disease management? What do you think? This might not come as a short answer for you in exam. Maximum it can be asked in a Viva. What do you think? Ishan, if you're comfortable with digital, it's okay to go with digital. Or if you want to write it down, it's okay to go with write it down. In this era, I feel digital is becoming more easier and you can save lots of things. Fine. Janvi, the recorded ones, yes, more or less, but the doubts might not be there. It'll be a bit crisper than your live lectures. Okay, one, obviously I'm going to help in diagnose, right? The pathologist's role in a disease management. When you use the term management term in case of medicine includes two things. One is diagnosis and treatment. Management is not just treatment, it's both diagnosis and treatment, right? So pathologist's role is primarily in the diagnosis, right? I'm going to help the clinician to narrow down to their differential diagnosis, and I'll tell you what exact diagnosis it is, right? It said that I'm a consultant. When a physician has a query, they ask me, then we go with that, fine? Okay. Theory Pro workbooks are nothing but predetermined templates which will be in sync with our lectures, fine? Okay, fine. So now pathologist as such, the pathology department, have you gone through your pathology department? How many of you have visited your pathology department? Did they take around the pathology department? Yes, maybe, no. Hi. You must have, right? So in pathology department, there are traditionally three broad segments of pathology. One, we have hematology. Hematology, as the name says, it deals with blood, right? Perfect. So one is hematology. The other department for me is cytology. The other department for us is histopathology. These three are traditional departments of pathology. Actually, there's new and becoming bigger, which is genetics. I'm into genetic diagnosis. So genetics of pathology is not very important for an undergraduate, but maybe very important from a consultant point of view, because most of these days they want to use genetics as a part of diagnosis. Fine. Okay. Great. So these are the three major departments under pathology, and I have a little bit of genetic diagnosis as well, right? So now let's see what I'll be doing for hematology, cytology, and histopathology. I am sure you must have had a very decent understanding of what happens in all these departments, right? Like you guys said, in hematology, we'll do related to blood, right? Can anyone tell me what else you think will come under hematology? Apart from blood, what will comes in hematology? Perfect, Tanmay. Histopathology is primarily the biopsies. Apart from blood, hematology has many other things. One, obviously, is your blood smear. You must have made your peripheral smear during your physiology, pricked your finger and made it, right? Okay. During the class is always better. CSF, I'll come to CSF, they don't come under hematology. One is blood smear, then obviously something goes in CBC. CBC stands for your complete blood count. If you have gotten fever, then your relatives must have sent you a report, right? Hemoglobin, TLC, platelet, neutrophils. That's your complete blood count. These are the chunk of work which is done in hematology. It will not stop with this. In addition to these, we also have bone marrow examinations that also will come under hematology. In few hospitals, lymph node also comes under hematology. Lymph node, spleen also comes into hematology. Because if you remember your physiology anatomy, all these are called as reticuloendothelial system, right? Doc Sam, I'm trying to learn Hindi. मेरा हिंदी थोड़ा खराब है, so इसलिए I am using English to teach. But you can definitely ask questions in Hindi. Teaching in Hindi will take a little bit of time. Fine. I'll use a little bit Hindi in between, but not very confident. It breaks my flow. That's all. Fine. Apologies for that, Sam. Okay. I'll go slow. Okay. Thymus. Obviously, thymus also comes into it, right? So all these places where I'm going to have leukemias, lymphomas, everything will come under the group of hematology in quite a few institutions. In few institutions, it's not. Okay. Fine. So next, in addition to this, we also have coagulation. Tell me, in your physiology, have you heard about this PT, APTT, everything? You must have heard it. PT, APTT. Sasuke, only accent is good. Vocabulary is not good. Perfect. Bleeding time, clotting time, prothrombin time, activated partial thromboplastin time, all of them. All of them also come under hematology. If I want to do a surgery, is it must for me to read BT and CT? I need prothrombin time. I need that, right? All the coagulation parameters also come into hematology. So I don't only help in diagnosis, I also help in assessment of a patient for a surgery. That's also required here, right? So we do need assessment. Okay, for assessment, pre-anesthetic assessment for surgery, again pathology comes into play. If I have to do an bone marrow biopsy, I need to know the platelet count. I have to take a pleural tapping, I need to know the platelet count. That also pathology comes into play, right? Maggie, antigen antibody assay generally goes to microbiology. It does not come into pathology. All of the antigen antibody is done with the help of ELISA. Dr. Mamta will definitely talk about that, right? Perfect, right? Now let's come to cytology. So what does cyto mean? Can anyone tell? Cyto means cell. Logy is the study of anything. Hematology is blood related study. Cyto is cell related study. Fine. Tanmay will definitely talk about prognosis very, very soon. Okay. It's cell related study, right? Perfect. Amazing. So can anyone tell me any investigation which comes under cell? Do you know anything which comes under cytology? Any investigation, like you said, BTCT, blood investigation, CBC, anything under that? For cytology, there are few important things. One, you must have heard about pap smear. You must have heard about pap smear, which is a test useful for screening cervical cancers. You might have heard, or we will definitely read about pap smear. How many of you have heard about pap smear? You have not heard about pap smear. Okay, pap smear is a screening test for cervical cancer. That's one of the examples. I thought you might have heard about it in the newspapers and many other things, right? Recently, pap smear became a huge controversy because one of the actors said that something happened, right? Fine. So cervical cancer screening, pap smear is a cytological thing. Some of you mentioned about FNAC. FNAC stands for fine needle aspiration cytology. I'll give an example of why this is required and where it is required, right? Have you gotten any injections when you're a kid, some fever, you must have got injections, right? So FNAC has very tiny needle. Let's say I want to look at some problem in the thyroid. If I take a biopsy of the thyroid, will thyroid bleed? With your anatomy, can I say thyroid is a very, very vascular organ? Yes or no? Swastik, I didn't want to take the name, right? So just why I said some actors. Definitely, right? So you will have a very vascular organ, and when I take a biopsy here, there's a possibility for it to bleed, right? If thyroid bleeds or if any organ bleeds, I will compress. Can I compress here to stop the bleeding? I cannot compress here to stop the bleeding, right? Because if you compress, you will choke the patient. That place, I use a very tiny needle, very, very tiny, the blue needle which used for injections. I poke it, dislodge, and look at the cells alone, right? That's here. So FNAC is done for lymph nodes, very, very tiny lymph nodes. You can't take a biopsy of a lymph node because entire lymph node is this much. The needle of the biopsy is bigger than that. So I poke that. Very deep lesions in the lung. It's very difficult for me to take the needle there. Go with the tiny needle and poke it there. Biopsy needle might be difficult, right? So things where biopsy is difficult, I cannot take a chunk of a tissue. I use a very tiny needle called an FNAC, right? Again, FNAC takes only the cells. That's second, right? Third, I have something called an NGC. NGC stands for non-gynae cytology. Gynecology is your obstetrics and gynecology. NGC your non-gynae cytology. Okay? Which is not involving pap smear. Everything else comes under non-gynae cytology, right? Okay. So let's look some examples for non-gynae cytology. You heard about a disease called as pleural effusion. When you read about pleural effusion, possible? Hello, Suraj. Which Vinayak oncology? Pleural effusion, have you heard about that? You might have, right? Perfect. So pleural effusion, can I say it can be due to bacterial infection? Definitely possible, right? So I need to prove it's due to bacteria. So I take a little bit of pleural fluid. So non-gynae cytology comes for fluids. It could be a pleural fluid. It could be a pericardial fluid. It could be an ascites. Ascites is nothing but the fluid in the abdomen. That's ascites, right? Perfect. So I can take the sample there and then I can say whether this is bacterial, viral, or due to cancer. CSF. I can take a sample of CSF fluid and say it's due to meningitis or due to some other tumor, because CSF can increase due to many, many conditions, right? I can help in the diagnosis. I can aid in the diagnosis. Urine. If I have an infection in the bladder or if I have a cancer in the bladder, I can look at the urine, right? any other fluid diagnosis, because fluid again is not tissue, they are cells. Anything which is undergoing cells, they come under the term cytology. I'm going to study the cells and not the tissue, right? That's the second second biggest branch of pathology, right? Last comes your histopathology. So what do you think we do in histopathology? Histopathology, the name is there. Histo means tissue. Histology is a study of tissues, is called as an histology. Histopathology is study of abnormality in the tissues, is called as an histopathology, right? Perfect. So many people have said biopsies, right? Perfect. It's completely right. I wanted to little bit change. It is biopsy only. I'll give you terms here because there's a first class and I want you to get used to these terms, fine? So I have something called an true cut biopsies or core needle biopsies. So what I do here is, if I have a big swelling in the hand, I don't take the entire swelling. I put a tiny needle, take just the tissue and come out. So most of the core needle biopsies will be like this. Tiny long strips of needle. That's how it will be. These are called as core needle biopsies. Fine, that's one. Second, I call something called an excision biopsy. Okay. So I'll tell you what does an excision biopsy mean. Okay. Have you heard about a disease called as lipoma? Or any guesses what do you mean by lipoma? You must have heard about lipoma. How many of you have heard about lipomas? Lipomas are nothing but lipid or fat related tiny tumors. If you've gone to surgery postings, you will definitely see them, right? It's a very tiny tumor in the skin, right? The lipoma's treatment is remove the lipoma. Tell me which is easy. Lipoma is a very benign condition. Nothing will happen for the patient, right? Which is easy? To put a needle, diagnose first and then remove a lipoma, or very confident clinically it's lipoma, just remove it. Which is right? To diagnose first, put a needle, take a biopsy, then remove it, or remove and send for biopsy? Obviously, removing and sending for biopsy, right? When I have a sebaceous cyst, it's a tiny cyst, right? I'll remove and send to the biopsy, right? Because lipoma can be easily diagnosed. I don't want to go and investigate that. For conditions which I can easily diagnose, lipoma, sebaceous cyst, tiny things, right? Where I excise the tissue and then send for histopathological examination. HPE stands for histopathological examination. So here, excision biopsy is, I'll do it Tanmay. Excision biopsy is both treatment, RX is for treatment and DX is for diagnosis. Initially, true cut biopsies are only for diagnosis. Treatment will follow that. Excision, I excise a tissue, that is the treatment for lipoma and also that is for diagnosis. That's called as an excision biopsy. I hope you understand the difference. Okay. Sure, Jayabadi, I'll do it. True cut or core needle biopsy is for diagnosis only. It's not treatment. I use it for diagnosis. True cut is the needle's name. Okay, Tanmay? The needle's name is true cut, which is a very long needle. I poke into tissue, I pull the needle, it will take in the needle's core a chunk of tissue. It will be like a needle. That's called a core needle biopsy. Fine. Okay, Jayabadi and Tanmay. Excision biopsies for conditions which I can be 100% right clinically. I don't have a problem at all, like sebaceous cyst, like lipoma, very simple conditions. 100% I am confident in diagnosis. I remove the entire thing. That's a treatment as well as the diagnosis, right? That's what we call it as an excision biopsy. I excise the tissue and then I send to the lab for diagnosis. Clear? Okay, right. Next, we'll come to incision biopsies. We'll see what does an incision biopsy mean. Fine. This is just terminologies just to get accustomed. Fine. Have you seen patients of diabetic foot ulcer? How many of you have seen patients of diabetic foot ulcer? Lalit, okay, biopsy is a procedure where if there's an abnormal tissue, I take a little bit of the tissue and then I look into the microscopy. That's a procedure called as a biopsy. Fine. You must have seen ulcers in images. That is enough for me, right? So you're having, let's assume it's a foot here. Okay. Not a very good foot. And I'm having such a big ulcer, right? Tell me honestly, is it possible for me to take the entire ulcer and to look into microscopy? Possible, not possible? Not possible, right? Because it's a huge ulcer, I cannot look into microscopy, right? But it's an open thing. So what I do here is, I take a tissue like this. I incise the ulcer. If it's a very, very large tissue and it's an open wound, you incise a part of it. Incision is putting a cut. That's what incision, right? Incise and then look for histopathological examination. I am not removing the entire ulcer, neither I am using a needle. The reason why I'm not using a needle is it's a big ulcer. It's already seen to me. Why should I put a needle? Only when it's not seen on the surface, I put a needle to take the tissue from beneath. I can see the tissue, so I take a part of it and give it. It could be a diabetic foot ulcer, it could be a penile ulcer, it could be an esophageal ulcer, it could be a gastric ulcer, anywhere where there's ulcer. When I can't remove the entire ulcer, I take a bit of the tissue and look it for diagnosis, right? That's an incision biopsy, fine. Next. Okay. So these all three things comes under biopsies, fine. We have excision, we have incision and true cut. These are basic things. We'll little bit add more when you go to deeper things, fine. Okay, yes, I'll do it. Definitely explain. Excision biopsy is both treatment as well as diagnostic. When I'm going to remove like a tiny lump in the breast, I remove the entire lump and then I look in the microscopy. Lump is a swelling. I have very, very tiny swelling in the breast. I remove the entire thing, look into microscopy. If I remove the entire swelling in the breast, that's a treatment and also diagnosis. That's excision. Incision and true cut are only for diagnosis. Excision is both treatment and diagnosis, right? HPE stands for histopathological examination. Good evening, Max Code. Okay. HPE stands for histopathological examination. Again, these are few terms. We'll get used to it very soon. It's nothing but I'm going to look at the tissue in microscopy. That's what I call as an histopathological examination. Sure, Sahil, I'll do it. Is red not visible? I am using mostly black only. If red is not visible, I'll definitely redo it. Fine. Okay. Then, like I said, I have genetics. Genetics is a very new and an extremely exploring branch, right? I have many, many things in genetics. Yes, Jayabati. To start with, yes. Balaji, like I said, excision is I remove the entire thing. True cut is I take only a tiny part of the lesion. I don't remove the entire tumor. Fine. Okay. Now let's look at genetics. Genetics is a very beginning thing. Broadly, I divide them into cytogenetics and molecular genetics. I'll not bore you much with genetics. We'll have its own sweet time when we learn about genetics, right? So cytogenetics means there are two major things which comes under cytogenetics. Have you heard about karyotyping? You must have read about karyotyping even in 12th standard, right? Karyotyping is something which comes under cytogenetics, right? And we have something called an fish. These are just tests. Just remember them. We will read what is fish, how to do fish, how to take care of things when we go into a genetics chapter. Fine. Okay. It's not boring, Punit. That's my entire life, right? We'll make it interesting. We'll make it interesting, intriguing, and I'll make sure after the class you'll say genetics is good, right? Fish is good. It's a fluorescent in situ hybridization. Okay. It's a test done for genetics. Fluorescent in situ hybridization. Need not worry about the expansions. We'll read many, many more things about fish when we come to into the depths of pathology, right? Then molecular genetics. I'm 100% sure you know the test. What did the test we did for COVID? Everyone knows that. Every world knows about the molecular genetic test. The test what we did during COVID. Every world knows about the molecule. Okay, sorry for that. Snehajit, we'll look at it. We'll look at it when you go into genetics. PCR, right? PCR and its modifications. RT-PCR is a modification of PCR. So I'm just writing PCR and its modifications. PCR, real-time PCR, reverse transcripted PCR, all the modifications of PCR comes under molecular genetics, right? Just a basic things. There are many, many more tests which comes under molecular genetics. At least we have to know about the PCR, right? So these are about genetics. So I have 4 departments in pathology. This is what I do. I help in diagnosis. RT is not real time. RT is reverse transcriptase. Q is real time, right? Generally it is used for real time, but it's actually is reverse transcriptase. Just to test your undergraduate knowledge, what do you mean by reverse transcription? If it's a very tiny ulcer, we might not require a biopsy. Unless I think of a cancer, I don't take a biopsy. Most of the cancerous ulcers are big. RNA to DNA, perfect. Now let's apply that, Punit, now let's apply that to real-time PCR of COVID, because COVID is an RNA virus and I cannot do a PCR on an RNA. So I take the COVID virus sample, I convert the RNA into DNA, and then I do a PCR. That's why I call that a reverse transcriptase PCR, right? Perfect. Okay. It's simple. So for every RNA virus, if I want to do a PCR, I have to do reverse transcription, because PCR can be done only on a DNA. It cannot be done on RNA. Why it can be done only on a DNA? That's also logical based. Have you read in PCR a step called as an annealing? Again, biochemistry, right? Thank you. Hello, guys. Yes, wrong, Puneet. That's why genetics is boring, right? So what happens is we have step called an annealing. RNA is single stranded. I cannot anneal. I cannot unwind it, right? DNA is double stranded. Then only I can push them into single strand. So PCR can be done only on a DNA. I need to make the two strands become one strand, make the complementary pair, then amplify. So which means only for a double stranded molecular genetic structure, I can do a PCR, which means I can do only for a DNA. I cannot do it for an RNA, right? That's all. Okay. It's an Saha, when I'm talking about RNA for a PCR, I'm talking about viral RNA, right? The viral nucleic acid metal is primarily RNA, right? So I take the viral RNA, convert to DNA, and I do the PCR steps. Fine. That's your real-time PCR. qPCR is for your real-time PCR. Okay, this is reverse transcriptase. Sorry, this is real-time. Q stands for quantitative. I can measure. So RT is for a reverse transcriptase PCR, not a real-time PCR. Fine. Great, Jay Krishna. Tanmay, because in PCR steps, if you remember your biochemistry, you will have a double-stranded DNA. You will cut them, make it into single-stranded, and provide complementary base pairs, amplify them, and then measure. These are the simple logical steps of PCR. I cannot unwind a single-stranded RNA. Most of the RNAs are single-stranded, right? So single-stranded, I can't do anything. I have to have a double-stranded DNA. Only then amplification is easy. RNA is a little bit unstable. I will not be able to do a proper PCR on an RNA. So DNA is much more stable. When I have lots of temperature, when it's an unstable RNA, it dies. So DNA is easy to amplify, and I need all the steps of PCR is based on the DNA, right? Perfect, great, amazing. Let's erase this just for a second, okay? So these are the branches of pathology, and I help in diagnosis. I help in assessment of a patient. I do help in prognosis. We look at prognosis soon, right? So next thing in your CBME curriculum is your common terms used. These are just basic things, like I said. Maybe let little bit of more extra time. We will make sure we will have no more doubts in these common terms. Once you know the terms, everything else will automatically fall. You must have heard about something called an etiology, AE or E, whatever you want. It's difference between American and the Britain English, right? Etiology or etiology both means one and the same. Why to confuse? We'll use etiology. Okay? Etiology. What do you understand by the term etiology? I'm going to use just few basic terms which will be required for our thing. Causation. Perfect. Okay. So I'm going to use two terms here. I'll be using these terms in a different way. Fine. Okay. One is etiology. One is risk factor. Because RT-PCR is RNA to DNA, real-time PCR will be measurement. That's the difference. Fine. Not the entire Jayavadi. I'll try to do in the RRR series if possible. Fine. Great, Roth. All the very best. Fine. So there are two terms here. One is called as an etiology. Like you guys said, it's a causation. Okay. Next term is risk factor. What do you understand by the term risk factor? Because we will use both these terms, and I don't want to get confused at any point of time throughout your medical career. What do you understand by the term risk factor? If etiology is causation, what do you understand by the term risk factor? Yes, Kajal. What do you understand by the term risk factor? Anything, any random thing, whatever you know. If you know, if you don't know, at least comment I don't know. It's completely fine. Which increase the chance of the disease. Great, Chitranjan. Potential to cause disease, may be a cause of the disease. Okay, great. Let's understand with this difference with the easy statement, right? Can I say, since we were talking about COVID, can I say COVID can cause pneumonia or COVID can cause throat pain? Is that statement right? It is, right? COVID can cause throat pain by default. A bacteria, streptococcus, can cause throat pain by default, right? It's Read With Me Robin series, which will be there on YouTube. Perfect. So I'm having a bacteria. I just take a simple example of a bacteria. This can definitely cause sore throat. Okay, it can cause sore throat. By default, it can cause sore throat, right? Now, can I say obesity will cause heart attack? Is this statement right? Or obesity is a risk factor for heart attack? Is this statement right? Which statement is right? With regards with obesity, will it cause heart attack or is a risk factor for heart attack? Perfect, RKL. It's a risk factor, right? Smoking causes lung cancer or smoking is a risk factor for lung cancer. Unfortunately, I'm antagonizing Mukesh in all the movie theaters, right? Smoking causes lung cancer or smoking is a risk factor for lung cancer. It's a risk factor for lung cancer. Diabetes causes heart attack or diabetes is a risk factor for heart attack. It's a risk factor. Perfect. So what do I mean by risk factors? Risk factor means there is a possibility it can cause. Chitranjan, smoking, the reason why I'm using risk factors, there are many people who smoke, but still they don't have cancer. Right? So I cannot, the risk factor of smoking and cancer is very high. So I'm going close to causation, right? But still it's a risk factor. Okay. It'll be great if you read William. Okay. So risk factors, not like RKL said, not everyone will have the disease if they have it, right? Obesity is a risk factor. Not that means every obese person will end up in having a heart attack, right? Obesity is definitely a risk factor. But when you're obese, definitely you have a risk of getting heart attack or coronary artery disease or myocardial infarction, whatever you want to say it, right? It's definitely a risk factor, right? So now I just want to use one more term called as relative risk, then we'll go to the next term, right? So I will use a term called as relative risk. Okay, this is more of an epidemiology term. You'll read to when you go to PSM, but this might be involved somewhere in pathology, so I'm using the same here as well. Fine. So relative risk of 1, it's a mathematical term. Let's say relative risk is 1, which means me and the general population is having same risk of having the disease. There's no difference in risk. If the relative risk is 2, I'm just giving a random example. This is not the right example, random thing. The relative risk of obesity causing heart attack is 2. So what do you understand by the statement? The relative risk of obesity causing heart attack is 2. What do you understand by the statement? Which means obese individuals has 2 times the risk than a normal individual for heart attack, right? Like I said, it's a mathematical terminology, that's all. Fine. It's completely a mathematical terminology. If I say relative risk of 4, which means compared to a normal person, this person is at 4 times risk of having it, right? A relative risk of smoking and cancer is close to 10 times more risk than a normal population. That's why it goes towards causation. More and more relative risk, more and more confidence that I am that this will cause the disease, right? That's what I mean. Fine. Okay. Yes, Punit, relative risk, you will learn a lot when you go to PSM. I'm just using the term here since we read about risk factors, fine? Okay. This is where our entire life is going to wind around. Pathogenesis. I have a normal cell. Okay. There is some etiology. Okay. Right. I have an etiology in a normal cell. The only question is, how does it alter the cell? That is my pathogenesis. I'm telling in very simple terms, that's my pathogenesis. Snehajit, you go to PSM, you'll learn lot and lots about relative risk, the parameters involved, the way to calculate everything. I'm just starting it, it'll be too much if I overburden and go into the depths of PSM, fine? Okay. So how it alters the cell is my relative risk. Like Vanishka said, it could be biochemical alteration, it could be your morphological alteration, it could be microscopic alteration, anything, right? It will alter the cell, that's all. How it alters is what we're going to read in pathogenesis. Let's take the same viral URI, right? So when a virus, now just to understand simple sore throat, because I am 100% sure everyone must have had sore throat, right? Can I ask a simple question? Virus is an intracellular organism or an extracellular organism? Okay, Srijan, relative risk means it's the amount of risk When a person is obese, how much they will have chance of having heart attack. That's relative risk, relative to the general population, which means non-obese population. If a person smokes, the risk of them compared to a non-smoker, that is relative risk. Fine. Why does this intro or extra? Clear, hungry, and Ghosh? Why does this? Virus? Comment, don't remove your comments. If it's wrong, it's wrong. No one cares about YouTube. I want you to get correct, that's all. Virus is an obligate intracellular organism. Viruses don't, they are not extracellular because virus cannot survive outside. Virus don't have the machinery. Virus is always intracellular organism, right? Perfect. So as an intracellular organism, let's take, I have throat. Okay. I'm having lots of throat cells, right? So let's say when a virus goes into these cells in the throat, right? Just a random, I'm using normal terms, not exact terms. No, Maggie, anakilla. Thankfully, illa. Fine. Okay. So I'm using this, right? So when the virus enters the throat cells, can I say it will destroy and damage the throat cells? Am I right in saying that? Because virus goes inside and it can destroy, right? Etiology is the direct cause, Tushar. Fine. So when the virus enters a throat cell, that's my etiology here, it will destroy the throat cells. So if my throat cells are being destroyed, will I be able to produce the mucin, whatever it's producing? Will it be dry or will it be wet? I'm destroying my epithelium of the throat. When I say throat cells here, I'm destroying the epithelium here primarily. I'm destroying all the epithelium. So will I be able to produce any amount of mucin? I won't. So can I say, when you have a viral URI, you will have dryness? Have you experienced that? That's simple pathogenesis. If I know how they are destroying, I can exactly say what will happen to the patient. Simple viral URI, it's going to destroy entire epithelium. If it destroys entire epithelium, I cannot produce mucin because you know for a fact you have pseudostratified ciliated columnar epithelium here. I'll get destroyed. I won't have mucin. Nothing will happen and becomes extremely dry, right? Prabhat, this might be a little bit more for DMLT students. I think you can see the general pathology. That is much more useful and bits of hematology. Fine, Prabhat. Okay. So that's what we read about pathogenesis. This is one example. But every pathogenesis from head to foot, it's the same. URI is upper respiratory tract infection. Sorry for using abbreviations. Okay. That's URI. Okay. Now this is what happens here, right? Now I have a cell. The beauty of pathology and medicine is this, right? Can I say my cell in my skin will respond the same way to a particular disease like a cell in my brain? Is that right? Or it will respond in a different way? These are cells. Can I say that? I have a cell in my skin. It will respond the same way like a cell in my brain. Will respond the same way like a cell in my stomach. Can I say that or I cannot say that? Any brain cell, Vivek. Okay, so anyone who said no, my question was different. I think your answer is different. I didn't ask about the outcome. I asked about the particular change. The symptom will be different. I agree that. If I have a cell in my skin, when virus enters the skin, will it destroy the skin? At the same time, will it destroy the brain? Will the cell respond the same way? I'm not talking about the outcome. I'm not talking about the symptom. Symptoms are different. Will the reaction be the same? Symptoms are totally different. I do accept. Will the reaction be the same? It will be the same. Perfect. So whatever I read in general pathology, right? Be it inflammation, can I say I will have the same neutrophil here as well as here in acute inflammation? Same lymphocyte? Yes. Cell death, necrosis, same here, same there? Undoubtedly same, right? My body will react the same. The symptoms will differ because based on the function, that is, right? Apoptosis will be the same. Autoimmune reactions will be the same. The cancers will be the same, right? These are my concepts. So concepts is not something I read once for every different organ differently. Concepts are something you read once, and use it for every single organ from head to foot, because I don't have major diseases. My diseases are very, very, very tiny. The problem with MBBS is students are not understanding the core crux. If I learn necrosis, my tip of the toe dies in the same way from my brain. If I know the physiology of the tip of the toe and the function of brain parenchyma, whatever cell it is, I will know what disease is going to happen. If I have a problem in my amygdala, I'll have a different symptom. Frontal lobe, different symptom. Temporal lobe, different symptom. But frontal lobe also will die with necrosis. Temporal lobe also will die with necrosis. Tip of the toe also will die with necrosis. Right? So this is what we are going to read in the entire pathology. So general pathology, please stay with me in the live class. Whatever doubts you have in general pathology, ask. I'll definitely help you out. Because once you complete general pathology, you don't require me. You know what is hematology easily when I apply the same concepts there. It's easy to extrapolate, right? So this is what we'll be reading, because pathogenesis is same for every damn cell in the body. It will not change. Symptoms will change based on the receptor, based on the function, based on everything here. Fine, perfect. Now a few more terms. Gross. Gross is something which I'm going to see with naked eye. If I can look at with a naked eye, I call them a gross examination. My finger is swollen. That's a gross examination. I don't want a microscope to say my finger is swollen. Right? That's a gross examination. So why do I need to know gross examination? Why do I need to know the liver is enlarged? When you go to a pathology, they must have shown you fatty liver and all the specimens. Why should I know this? The answer is very simple. Okay, I'll finish in maybe 10-15 minutes more. That's all up, roughly. Okay, so anything with naked eye is called as a gross examination. Not everything, yes, quite a few of them will have tertiary structures. Fine. Okay, so gross examination as on date in 2023, 24 and 21st century, I don't require you to know the gross examination for every organ, because I am not diagnosing any tissue by looking at gross, but gross will be almost equivalent to radiological examination. If I say a gross lesion is solid versus if I say a gross lesion is cystic, I'm sure you know what is cystic, right? Cystic is nothing but cyst. Why 39 minutes, Richard? Cystic is nothing but fluid filled structure is cystic. Can I say solid will have a different MRI, CT, X-ray finding compared to a cyst? Definitely it will, right? So like I said, paraclinical is a link between your clinical examination, clinical diagnosis. If you learn that today itself, tuberculosis will cause cavity or a cyst, you will know what to see in an X-ray. Right? You will definitely know what's seen in X-ray. Kajal, cyst is nothing but a fluid-filled structure in a body is called as a cyst. That's a cyst. You must have had, have you had boils? When you cook, accidentally some hot liquid touches, you'll have a cystic structure. That's a cyst, right? So gross examination primarily in this century is only for me to extrapolate to radiological findings, because I don't look at the lung, cut out the lung and say it's tuberculosis. I am much more evolved. I can easily say what is tuberculosis, right? So I don't require this. Fine. Cyst is mostly membrane bound. Yes, Bibik, you are right. Snehajit, cyst and pus is not the same, but both of them will have a cavity which might look in a radiological imaging samely, or based on the contents there might be a little bit change in the shadow. Right? Now, my lectures will be 2 days in a week. Perfect, right? So it'll have an altered echo texture. So whatever you read in gross in pathology, I might not emphasize more because it's required to some extent. The only use of that is to compare that in a radiological finding when you go to final year to arrive at a conclusive diagnosis or a differential diagnosis, right? Thus, my Hindi is a little bit awkward, so only I'm not going with Hindi, right? I'm learning Hindi. You please teach me Hindi. You can ask doubt in Hindi, right? I will definitely answer, but slowly in English, fine? Okay. Jamu, this is a very introductory class, might not have DPP. From the next class, we'll have DPPs, fine? Okay. Let's come to microscopy, fine? I will use the term MX for microscopy. These are few abbreviations. SX is for surgery. There's a few abbreviations you will definitely learn on the go. That's for surgery, and MX for microscopy, right? Microscopy is something I'm going to see in the microscope, right? In microscopy, you have stains. Can anyone tell me what's a normal stain used for biopsy? What's a normal stain used for biopsy? The same stain which is used for histology. What's a normal stain? It is H&E, right? Don't ask me why they say H&E when it's eosin and hematoxylin, or hematoxylin and eosin, right? So eosin and hematoxylin is a normal stain used. Okay. I can use eosin and hematoxylin. That's a routine stain useful for almost every biopsies, almost everything. It's H&E, eosin and hematoxylin, right? Apart from that, I might have a little bit of different stains for different investigations, right? Hematology. I am sure you must have done that. What was the stain you used for finger prick smear in your physiology practicals? What's the stain? I don't do H&E in hematology. What's the stain there? The common stain used in hematology is, have you done this stain? A Leishman stain. Perfect. Because hematology is a different thing. I cannot do an eosin hematoxylin. I use a Leishman stain, right? Perfect. Which wala part in pathogenesis I'll zone? Please explain. I'll definitely explain it again, right? And I have one more stain in hematology called new methylene blue stain. I'll talk about new methylene blue in detail when we come to hematology, but generally we use Leishman stain. That's a basic stain used for diagnosis, right? In cytology, I have two stains in cytology. One is PAP, called as Papanicolaou stain. That's used primarily for pap smear and FNACs also. And I have one more thing called as GIMSA. Okay. So PAP and GIMSA are stains used for your FNACs, cytology. In entire cytology, I have PAP and GIMSA, fine. Etiology versus risk factor wala or pathogenesis wala? Pathogenesis is different from etiology. Etiology is the cause. Pathogenesis is what happens in the body. Fine. Okay. So next for histopathology. Histopathology, I have something called an H&E, which we already discussed, right? That's a basic stain, right? Perfect. Methyl-free alcohol is the fixative of your Leishman, right? So now, can I say I cannot diagnose everything on histology? Sometimes I require extra stains. Like Maggie said, PAS might be required. Might be definitely required, right? So sometimes H&E alone is not enough for me. That time I have something called an special stains, right? I have special stains here. When I cannot diagnose something on a H&E, I use a special stain. Special stain, we'll read lots of special stain, like Maggie said, PAS, Alcian blue. There are many special stains, right? I cannot diagnose on H&E. That's something which I want you to remember forever. If you can't diagnose on a H&E, I need stains. Okay, please do remember this. Never forget this. Because over the period of time, I hate entrance examinations. I'll be very frank about it. Because entrance examinations is unfortunately not making doctors think. You don't read tables for clearing an exam in medicine, then you are a student, you are not a doctor. When you join MBBS, you're a doctor for me. I don't care how much you score. I care only how well you treat. That is the ideal goal for every aspirant here, every student here. I don't read tables. I read when there is a need. I don't memorize things. I treat when it's a requirement. That's what is required, right? Papis Papanicolaou, George Papanicolaou, the guy's name, fine. Remember Pap, that should be more than enough, Yash, fine. Okay, so if I have a requirement, I will read. If I don't have a requirement, I don't want to read, right? Because if it's not required, please remember from today, take this into your head clearly. Can I say your NEET exam, NEET PG or next exam, whatever is going to come, the exam paper setter will be easily 50 years old, or it'll be 25 years old? What do you think? The exam paper setter will be easily 50 plus, right? Perfect. Please tell me which exam paper setter who is in 50 years old will know the root value of any nerve. We can't remember root values of nerves after 2 weeks, right? Can you remember? You can't remember. But can I say the 50-year-old person will definitely remember Erb's palsy? because they see patients. Might remember Klumpke's paralysis because they see patients. So what you read from today going forward, if it's useful for a patient diagnosis, management, or anything related to patient, a consultant will remember. Otherwise, they don't remember. If you carefully observe, whatever root value is being asked will always be related to clinical correlation. If it's not correlating, don't remember. So like that, I need a reason. If I need a reason, I can remember. You will also remember when you become a consultant. Only when you remember, you can ask MCQ, right? Do you think a person who's setting questions for exam will go and take the textbook? We don't take textbook for exams. Why will a person take textbooks for exams? They don't, right? Never ever memorize things, because if you memorize, it'll give you an instant gratification. I know so many things. After 2 days, amygdala will say bye-bye, it'll go away. But if you form a link, this is the one which causes long-term memory. Again, going back to your neurophysiology, right? Always, Jay Bharti, always been correlated clinically only. Few questions comes here and there, few random questions. Leave them. 80% first rank. I don't want 100% here, right? So when you form a link, that's what I want you to remember. If I cannot diagnose something on HNE, I want you to form a link. Think of a special stain. Then you will know that, okay, this is the special stain I'm going to use. Form a link, it's always easy. That's why I said, remember general pathology, form a link with brain, form a link with CNS, form a link with CVS, form a link with liver, GIT, same necrosis, link. You know the normal, you know the abnormality, you know the symptoms, you know the diagnosis. Very, very simple, right? Now, there are a few special stains. We use the term special stains or markers, right? So special stains or it'll be markers. These are just two abbreviations which you want you to know. Immunocytochemistry. Vinayak, if you want to solve clinical scenarios, I would say Robin's review book is there. If you're there, a part of my Telegram group, I'll share the book to you. Just a PDF. It has good source of clinical questions. Fine. So immunocytochemistry is the special stains. What I do on cytology smears. I do an FNAC, but I want to do a stain that happens, right? Then my physiology is gone. Memory body. Sorry, the memory circuit, right? Okay. Amygdala for your emotions that triggered that. Okay. IHC is your immunohistochemistry. The stains are used for histology or histopathology. I call them immunohistochemistry. Fine. So I have two different terms, immunocytochemistry and immunohistochemistry. Fine. Okay, I'll do Jayabati for sure. Okay. So these are few markers. It's a few terms which I want you to remember. Just a quick recall of the terms. Etiology was risk factor. Etiology is a causation. Risk factors increases the risk. That's all. Fine. Rasbi, it is closed group for 2023 batch students. If you're following me on Instagram, Dr. Ranjith AR, I'll share the link there. You can join there. Fine. Because I don't want spams there. That's why I kept it closed. Fine. Okay. Then pathogenesis. Pathogenesis means be it etiology or risk factor, what change it is going to cause in the cell. Particular cell, be it biochemical, be it microscopic, be it functional, whatever it is, I am going to call them as pathogenesis. Fine. So then morphology. The gross morphology is something which you can see in naked eye. The only reason for remembering them is it is easily correlated to radiological investigation. So I can use it for diagnosis ultimately. Fine. Then microscopy. Any change what we see in your microscope, I'm going to use it in microscopy. General stains used will differ based on the investigation. I have Leishman stain for hematology and new methylene blue, cytology, PAP and GIMSA, histopathology. If I'm not able to identify something on histopathology, I use special stain, right? PS, Alcian blue are not IHCs, they are special stains. I have special stains and then I have markers. Special stains don't use immunological antigen antibody reaction. IHC is something which use immunological antigen antibody reaction. So that's a word I have, immunohistochemistry and immunocytochemistry. If you use antigen antibody reaction, it goes there. Fine. Okay. No, it's not closed. It's a private group. That's all, Ajay Bharti. Fine. Rahul, why your Pathoma? Pathoma is an amazing source. The only thing is it's more oriented towards an MLE based exam. That's my only thing. If you are going to stay back in India, I would say go with our sources. If you want to see, because Pathoma is a source to crack the exam. That's all. To crack the USMLE exam. It's meant for that, right? First aid is meant for that. Reading that and doing a different exam, you might little bit struggle. I'm not saying you will fail. You might little bit struggle. That's why if you're aiming for a USMLE, go with that. Okay. If you're aiming for USMLE, definitely go with that. Future medicos, my MBBS was from Kilpauk Medical College, Chennai. PG was from Jimma, Pondicherry. Okay. Last but not least, what is prognosis? Can anyone tell me what is prognosis? I'll take your queries. We'll wind up with this term and then we'll definitely take your queries. What do you understand by the term prognosis? Prognosis? Anything? Or if you don't know, come and don't know. That also is completely fine. Course of the disease. How serious is the disease? I'll share the link. You can join it. How the disease occur after treatment. Great. Recovery. Okay. So when I say the term prognosis, it's the course of the disease or the patient's outcome with therapy or sometimes even without therapy. Prognosis is a term generally useful for a standard therapy or even without the therapy, right? Perfect. Prognosis is nothing but the outcome of the disease with or without therapy. Prognosis for URI, 7 days, automatically it will stop, right? It might go to pneumonia, that's a complication, right? Prognosis of a cancer, if I don't treat, it goes to death. It'll definitely become worse and go to death, right? Okay, so outcome of the disease is the prognosis. It is maybe with or without treatment. Generally, your books will ignore the second half. That's without treatment, right? I'll tell you why it has been ignored and why it's been not told to an undergraduate also. If a disease is cured without treatment, why should I worry? So generally, when I treat the patient, how fast the patient is going to heal, or what are the factors which will determine how fast the person will heal, or when will the person heal, or will the person even heal? So that's what is meant by prognosis. Is the outcome of the disease or the treatment is a prognosis. Fine. Perfect. I'll tell you, Ajay, 1 second. Okay. Tanmay, special stains and markers. Markers, immunohistochemistry and cytochemistry are immunologically based. PAS, Alcium blue, will not have an antigen antibody reaction. It's a stain like Leishman stain. I pour something and make the color appear. But special stains of markers of immunocyte and immunohistochemistry will always have antigen antibody reaction. That's the difference. Fine. Thank you, Maggie. Okay. Perfect. Yeah, that's an easy way to remember, right? So that's all for today. It's just two basic topics. What is there in your CBME curriculum? The simple terms in with respect to pathology and what does a pathologist do in respect to disease management, right? So if you have any doubts, do let me know. If not, we'll call it a day. See you on Monday. Hopefully by Sunday, I'll definitely take care of your workbook for the first chapter and I'll send it to you guys. Fine. Prabhat, if your college gives some books, that will be the best source. Snehajit, outcome means the patient's outcome. How fast the patient will get cured, how fast the symptoms will disappear. Everything is the outcome. Fine. Vinayak, I'm okay with any book, South Asian edition or international edition. If you buy a book, buy a South Asian edition. But I think ebooks, most of them are from international edition, right? Final exam, Ajay, you are if you're in second year final exam, we'll have Foray series for you. Please follow that. But if you're asking about the final exam of your MBBS final prof, you have to be strong in more clinics. Theory, you will definitely pass an MBBS final prof. Fit doctor, you are in second year and preparing for AMC. Rasvi, Tamil, I'll start a different channel. Say Tamil padikalan. Okay. Dr. Ranjith AR, Kajal. Etiology is the cause. Risk factor is risk of having the disease. Pathogenesis, what happens due to the etiology and risk factor. Fine. Because Prabhat, your syllabus is very restricted. That's why I said go with the college thing, whatever they say. Fine. Yes, Sushil. 2 days of patho, 2 days of micro, and 2 days of pharmacology. You can go with PW Telegram channel, which will be there in the link in the below this link. That also will have all the thing. I'll put there as well. Fine. Okay. Yes, Hungry Nomads. Papa Robin is always better. More bigger the book you read, more stories it will have, more easy to remember. I'll put it in the Telegram channel of PW as well as in mine. Okay. Okay. Jay Bharti, prognosis is like I said, how the disease progresses is prognosis, whether it be good or bad based on different factors. Same like COVID. COVID can recover, COVID can go to pneumonia, that's a prognosis, fine. Should be enough, Snehajit. It will come out soon, very soon. Lesh, Robbins is good. Why to go for second best, right? Let's go for the best. Srijan, for everyone who asked this, like, should it be before the lectures, read Robbins, or after the lectures? I would want you, there are recorded lectures available, right? This Saturday, Sunday, do this as an exercise. Take one topic, first read Robbins, then see the lectures. Second topic, see the lectures, then read Robbins. Whichever is better for you, go with that. Because something might be good for me, will not fit you, right? So just half an hour topic here and there, do both the ways, whichever is best, go with that. HKR Hashmo is a good book. I'm not denying that at all. But the only reason why I'm insisting on Robbins is every chapter of Robbins is written by 3 or 4 pathologists. So the amount of knowledge and experience you will get from that is definitely way more than a book written by one person. Even if I write a book in future, I will still say Robbins is better. 10th edition is more than enough. Pathology lectures on Monday. Tomorrow, I think you'll have microfarm in the next 2 things, fine. Pathogenesis is nothing but what a disease or an etiology is going to cause to a cell or an organ is a pathogenesis. Prabhat, your university exam, Prabhat, your syllabus is very short and restricted. That's the only reason I told to go with the thing because Robbins might be too much for an MLT student, Prabhat. My lecture is on Monday next. Tejaswini, if you like the lectures, please come and attend our class. Fit Doctor, the duration of every class which will be going forward, the complete class will be there for 2 hours, 6:30 to 8:30. This is just an introductory class, so we had for an hour, that's all. Harshada, let's do one thing. Let's read Robbins this year, okay? Let's create a beautiful notes out of Robbins. You will remember that notes and get an amazing mark, get an honors, and tell your junior you can do it. Let's be an example, right? Why to listen to our seniors? You be the example and tell every junior after getting an honors or distinction or whatever it is, or maybe a university topper, then tell to your juniors, read Robbins, make your own notes, definitely you can reproduce an exam. Okay. Snehajit, I am trying to do it every single day, 9 to 10. Let's see if I'm not able to do it on 9, if there is any other lecture, I will not be able to do it. I have put the schedule for the next 6 days in the Telegram channel. Okay, you go with it. Great, Tejasvi. Nilesh, like I said, you read once, let's see what happens, and one day come without reading. Whichever is working for you, do with that. Fine. On app, 6:30 to 8:30 will be the regular classes, which will start from Monday. You'll have 3 days of introduction, one for patho, one for micro, and one for farm. Aisha, Robinson Kumar is a smaller book. Robinson Kotran is a bigger book. The new Robinson Kumar's big book has not yet come. So I'd say Robinson Kotran, go with that. It's decent, Nawaz. Unless you go to 7th edition, 10th edition or 9th edition is more or less same. Not much of changes. Very small changes that will cover in the classes. Srijan, the mistake to avoid, don't stop reading. That's the only mistake. Don't procrastinate. If you read every single day, no, not just pathology, every subject will become easy. Okay, got it. Fit Doctor, whatever works for you. iPad or a hard copy notes, whatever works for you, go with that. But the only thing is don't lose them. I'm okay with anything. If you ask me, I will still be comfortable with the iPad because colors, everything are much easier here compared to any notebook. I did answer that, Aisha. Robinson Kotran is what I'll prefer. If the 11th edition basic pathology, pathologic basic of ribs of Robinson Kumar comes, we can switch. Right? Stay with me for the next 4 months, Hungry Nomads. I'll make sure you understand pathology the best way possible. Fine. You'll have that, Vinayak. You'll have it. Immunohistochemistry is a term, it's a marker study useful for biopsies using antigen-antibody reactions. That's what immunohistochemistry means, Antima. I'll do it by Sunday. I'll definitely give it to you. Before Sunday also, I'll put it across. Let's see. Okay. So thank you guys. See you soon. See you. I'll make sure that the app comments works well. Yeah. So unfortunately, it didn't work today. Okay. Practical manual. Your college will have a routine thing. Go with that. I'll try to cover the slides. I have the slides. I'll share with you guys as well. Gross also. If I have few images, we'll learn slides and gross also together with the topics. Fine. Okay, guys. Good night. Bye bye. See you. 7 months approx fit doctor. That's what I'm planning for. Hopefully it goes well. Okay, Kalyani, gross pathology with radiology, right? When I have a solid lesion in the gross, X-ray might not pass very much, so it looks a little bit different color. Cyst, water filled or fluid filled, the lights pass a little bit easier, so a different color. Fine. Yes, Chirag. Okay, guys. See you. Thank you. Bye bye. See you. Bye bye.